first? I think that'd be. Well, good afternoon. Good to see you all. Welcome. So glad to be doing this again. And I see all the smart people are here. I can tell now. I'm just making a check. Oh, Helen's here too. Are you saying she would qualify in that group? Yes, I think so. She's hiding back there, they said. No, she can't hide. She stands out in any group. Well, so appreciate the support that this core group of devotees who've been so faithful to come to our talks. I really appreciate it, and we enjoy it. I hope you feel that they're worthwhile, and your coming suggests that to us anyway. That's the way I'm going to read it. So. Um, so, as the usual format, most of you have been here before. The two resident physicians, young doctors who are here for the month, their last week on this Wednesday, they make a presentation of a topic that's got enough common recognition or problem that that people would be interested in hearing about it and need more information on. And so I think you'll probably agree that what we picked this time, low back problems and hip problems. You know, bones, joints, and muscles are the source of a great deal of pain, and it's certainly not limited to those two areas, but it seems like sooner or later everybody gets back problems. I, for one, have. And you know, is there anything that makes you feel instantly 20 years older than getting down in your back? Golly, it's hard. And I'd like to say we've got all the answers for it. You'll leave here, you know, so enlightened that you'll cure yourself next time you get it, but maybe not. And we're in terms of a disclaimer, we're not orthopedists, we're not back specialists, don't claim to be, not neurosurgeons, but we see a lot of folks with back pain, and we learn probably from every case if it's bad enough that we have to refer to someone, we'll learn from that case. And there's a lot of common patterns, and so I hope our experience and our understanding, even though it may be a little limited, might be helpful to you as we discuss it today. Sometimes I think hip pain, not in the joint, but in the bursa here, is the most common thing I see sometimes. It is such a common thing, and it's unlike arthritis, it's actually curable. So we always look for that. But hip problems and low back problems seem to be the biggest thing coming forward. Well, with that said, let me introduce the residents we had. Some of you have met them as they've been here this block this month. We typically have an upperclassman and a first year is a very common pattern. That's what we have this month. Dr. Joseph Kuhn is a second year resident, so an upperclassman. This is a 3-year program, so 1, 2, and 3 years that we have him here. And Dr. Kuhn's in his second year. He's a native of Little Rock, went to Ouachita Baptist University, undergraduate, and to UAMS for medical school. And the proudest thing he would say is his marriage and his daughter, who's 16 months old, Miss Eleanor. Name for a first lady, right? Maybe, I don't know. It's not a name that's used as much as it used to be. I love Eleanor. So, and sitting right behind him is Dr. Benjamin Frazier. also of Little Rock, coincidentally. Uh, Ben, you went to the University of Arkansas, right? Undergrad, and in St. George's University to get his MD, and he's in his first year, so just received his MD back in May, and now is starting his internal medicine training. And I'll tell you something special to me about Ben is we've already spent more time this month together than we ever did during his growing up, but I certainly know him and his family because his father, who's a hand surgeon at UAMS in Little Rock, his father and I grew up across the street from each other. You know, my father was a small town doctor, Hope, Arkansas. He wanted all 4 of his kids to be doctors. I was the only one crazy enough to do that. But his father across the street apparently got influenced, and so he went into medicine. So I tell him much more than his father, his grandfather, who was just the most prominent civically minded person in town, George Frazier, wrote me a letter of recommendation for medical school. So I give him some credit for my getting in medical school. So anyway, it's been fun getting to know Ben better this month. So with that introduction, I'll hand it over. I think Dr. Kuhn's doing his part first.
Thank you very much, guys. Thank y'all very much for coming. Thank you for that excellent introduction. So like he said, my name is Dr. Joseph Kuhn, and I'm going to get started with lower back pain. That's my section, and then Dr. Frazier will be talking about hip pain. So first, let's get started with some anatomy. I think that's a good place to start so we can understand our landmarks and what part of the back we are and are not talking about. So when we talk about the lower back, it's important to talk about your areas. So this is obviously the rib cage, and then you see the vertebral column behind that. And you have your sternum right there in the middle. And then the section of the back that is considered lower back is anything below those red lines. So you think below the rib cage is going to be lower back, and that's also going to correlate with the lumbar spine. And here is a graphic of that. So you have the cervical spine, which includes 7 bones, the thoracic spine, which includes 12, and the lumbar spine, which includes 5. And anything below that red line is going to be your lower back. And then next to the graphic there, you have another set of pictures, which are just kind of cutaways of what the bones look like on those levels. And the little white holes there is where your spinal cord passes through. So those are the nerves that go from your brain all the way through your body. And if you can imagine that if you had a misalignment there, whether a slippage forward, backward, or some kind of a lateral movement to the right or to the left, you're going to pinch that and cause a lot of pain. And that kind of pain is where you get sciatica, which is shooting pain that goes down the leg. And then another landmark I want to mention is the sacrum, which is that reddish brown color there on the bottom. And that's another area of the body where women are prone to fractures. And I can come back and refer to this later if you have any questions about that. So there are several different kinds of ways that you can categorize the types of lower back pain that exist. The first way that I'll start off categorizing these are by the types of causes of back pain. So the first group of causes that I'll talk about are the mechanical causes. So the first one is vertebral compression fractures. These present as sudden onset severe pain. It may resolve, the pain may resolve after 4 to 6 weeks, but this pain is exacerbated with any movement of the spine. Forward, back, side to side, it doesn't matter, it's going to make it hurt more in that spot. You're usually not in neurologic deficit, so you think of like muscle weakness or something like that. You're not necessarily going to have that here. And then how do we see this? How do we determine you have it? You get an x-ray of the spine and you can see it there easily. The other mechanical cause is an osteoporotic sacral fracture. And that's that part that's just below the lumbar spine that I was talking about. This presents with sudden lower back, buttocks, or hip pain, and also sacral tenderness. So if you press on that part of the bone, you'll be tender there. And this, you can certainly see this on x-ray, but it has a characteristic finding on bone scan. It has a little bit of an H-shaped uptake on the bone scan, so we can see it that way too. And then anatomic causes of lower back pain include scoliosis, which I'm sure you're all very familiar with, but is an abnormal spinal curvature, usually identified in children at 10 to 12 years of age, maybe earlier depending on school screenings. And this can present with gradual worsening of pain over many years. And obviously it presents with abnormal spinal curvature that you can see just on examining a patient or on x-ray imaging. The next group is degenerative causes. The first one I'll talk about is disc herniation. This presents with sudden onset, severe back pain, and radiculopathy, which is just a fancy word to say that you're going to have shooting pain to other parts of the body, not uncommonly including down the legs. An examination maneuver that we'll do to elucidate this is the straight leg raise, which is when we'll have you lie flat on the examination table, and then we'll have you hold your leg out straight, and then we'll raise your leg up to maybe a 45 to 70 degree angle. And by doing that, you'll sometimes have pain in the back, but the test is positive if you have pain that shoots down your leg. So not just the back pain, but you also need to have pain shooting down your leg. It can present with leg weakness, and this can also be seen on an MRI. Lumbar spinal stenosis is also very common, and it presents with pain on standing and walking that is relieved by sitting and lying down. And this, you may have a little bit of an immobile spine where you try to fixate into certain areas that are not painful to you, and this can also be seen on MRI or CT scan, and I'll talk about that one later. Spondylolisthesis is a fancy word that basically means slippage of the vertebral body, and it presents with lumbar pain with activity, gait problems, and radiculopathy, which again is just that shooting pain. And on exam, what we'll find is a palpable step-off sign at the lumbosacral area. So if you remember that picture that I showed you of the spinal column, when we palpate your bones there going down your spine, you can palpate a little bit of a step-off where there's like a misalignment where part of the bones are slipped forward. And you can also see this on imaging. The next group of causes is infectious. Spinal abscesses, osteomyelitis, and discitis are all common causes of infectious back pain. They all present with localized tenderness, redness, and warmth at the site of the infection, and you may have possibly systemic symptoms, which include fevers, chills, sweats. On exam, they all present with tenderness, and redness, and warmth at the site. And regarding testing, we may get a CBC, a complete blood count, to see if you're having an elevated level of white blood cells. With osteomyelitis, we may order an ESR or CRP, which are inflammatory markers that can be specific for osteomyelitis. And we can also get imaging, such as a CAT scan or an MRI. And with discitis or osteomyelitis, we may recommend a bone biopsy, which is a way that we can determine exactly what is the infectious organism that's causing the pain. Malignant causes, so the first one would be a tumor, which can present with progressive, persistent pain at rest even. So this one is a non-positional type of pain. It doesn't matter if you're lying down or if you're walking or bending over from side to side, it's just always there. You may have systemic symptoms including fevers or weight loss. And on exam, it may be an unremarkable exam. On laboratory testing, you may have anemia, increased inflammatory markers like an ESR, or abnormal imaging. Metastases. Patients that come in with metastases to the spine will usually have a history of cancer of some kind. One that we commonly think of that goes to the spine would be prostate cancer. And this can also present with fevers and weight loss. And again, this can be seen on imaging, of course. Multiple myeloma is a type of blood cancer that can present with bone pain. You may have systemic symptoms with this as well. And on laboratory evaluation, you may have an elevated calcium level, abnormal proteins, kidney abnormalities, or anemia. So another way that I can talk about, and that I will talk about, types of back pain is how do they present. I talked about it a little bit before, but I'll talk about it here again in a different way. So if you develop acute back pain, sudden onset, possibilities include vertebral compression fractures, disc displacement, osteoporotic sacral fractures, or some kind of a visceral origin, which may mean that it doesn't necessarily have anything to do with the back at all. It can be something like an aortic aneurysm, an aortic dissection. It could be problems with pancreas or kidney stone. These things can all present with the chief complaint of acute back pain, but maybe aren't related to the back necessarily. So if you have positional pain, which would be increased pain with standing, walking, and relieved with sitting down, this could be lumbar spinal stenosis or mechanical back disease. If you have persistent pain that is present no matter what position or what you're doing and is gradually worsening, that could be signs that you have an infection or a tumor of the spine. How do we examine the spine? First thing that we'll do is we'll take a look at your back. Does it look symmetric? What's your posture like? Do you have any tenderness of your back? If we go up and down the spine, is it tender? Take a look at your hips. I mentioned the straight leg raise, where we lay you flat as well and raise your legs up to see if you have leg and back pain. Assess your gait. The gait is one of the best tests of just in general, because it assesses your cognitive abilities, your ability to maintain appropriate balance, your ability to determine the position of your feet in space, but it also helps us to determine what's your back like, and are you having to kind of slouch over a little bit to relieve pain in your back. One thing that we'll do is have you stand upright, and we will move your back to the four planes of motion, so that would be forward, back, and side to side. And another thing that we may ask you about or assess is if you're having weakness in certain parts of your body, such as difficulty raising your big toe, problems abducting your hip, which would mean to separate it from the body, so bringing it out to the side, or hip extension, which could cause weakness with standing. If you have paravertebral muscle spasms, which is just a long term to mean you have spasms in your back that run up and down the spine, could be a sign of mechanical disc disease. If you have asymmetric range of motion of the lumbar spine, again, it could be mechanical disc disease or unstable lumbar spine. Oh, I'm so sorry. There you go. If you have spinal tenderness, could be vertebral compression fractures or infection. If you have weakness of, like I was mentioning, weakness with your toe, like maybe weakness of the large toe, or problems with abducting the legs or bringing it far apart, bringing it back in, or weakness with standing, it could be a sign that you have mechanical disc disease or lumbar spinal stenosis. And you may present with a normal exam, but that doesn't necessarily mean there's nothing wrong going on. You could still have an osteoporotic sacral fracture, hip disease, a tumor, or some kind of referred visceral pain, which again could be pain that presents with pain in the back but isn't necessarily a problem with the back. When do we get imaging of the back? It's largely recommended that if a patient presents with back pain that you wait at least 6 weeks before imaging the back, except in certain conditions, and these are those. If a patient comes in with red flags, such as concerns for a vertebral compression fracture, acute neurologic deficit, so like muscle weakness or numbness, dysfunction or sudden incontinence of the bowel or bladder, where you didn't used to suffer from this before, but now you notice that now you can't control your bowels or you can't control your bladder, that would be concerning. If you start having fevers, or if you have a history of cancer, like prostate cancer, now you're having back pain. Some of these can all be indications for not waiting the full 6 weeks and going ahead and ordering back imaging. Some systemic causes of back pain can be due to tumor or infection. These can have an insidious onset. So again, it's kind of like the idea of a frog in the boiler, where the frog doesn't necessarily know that he's being boiled until he's been in there for several minutes and dies. It can be kind of like that, where you may have back pain slowly progressing and you don't really notice it until maybe years down the road, and you're like, well, I don't really know when it started, but I've had it for a long time, I guess. This pain can be non-positional. can occur even at night without movement. And again, you may have those fevers, chills, sweats. Risk of cancer as a cause of back pain increases in adults more than 50 years old, or those with a previous history of cancer, or those with pain that persists for more than a month. And if you have fever, discrete local vertebral tenderness, pain in the upper lumbar or thoracic area, or non-positional pain, that can indicate a vertebral infection. So lumbar spinal stenosis, I told you I'd talk about this again, and this is when I'm talking about it. So lumbar spinal stenosis is the most frequent indication for spinal surgery in individuals older than 65. And the diagnosis of this is a little bit tricky because patients can have imaging findings that are concerning for lumbar spinal stenosis, but they need to also fit the clinical picture. So it's not enough to have imaging findings, you must also fit the picture. And with this, you'll have pain in the back, buttocks, thighs, and legs. The pain will be positional, occurs with standing and extending the spine. It can be worse with walking, and it can be relieved by sitting or forward flexion. A sign that we're taught about this is the shopping cart sign, where you bend over, and not because you bend over to walk, and not because of bad posture or stiffness, but because that's the only place where you don't hurt in your back. That can be a sign of this. It can also present with sciatic pain or pain in the calf while walking. How do we manage it? Conservatively, physical therapy, exercise regimens, oral pain medications. Some patients do require surgery, but for those who are not eligible for surgery, then what we'll do is we'll recommend a rolling walker with an attached seat. So like I said, these patients need to bend forward to relieve pain, so a walker can be helpful, and having the ability to sit down can also relieve that pain. Sciatica affects young and old patients, and it can occur spontaneously without any known cause. It can be present in any condition, doesn't necessarily go away when you sit down. It can be present even at night. And the nice, good thing about sciatica is that up to a third of patients will resolve their sciatica without treatment within 2 weeks. And 3/4 of patients will have no symptoms after 3 months without any intervention. Vertebral compression fractures, these are also very common, but only a third of patients may have any symptoms at all. And the symptoms will be abrupt, severe pain, usually worse on standing and walking. It's seen on an X-ray or a plain radiograph of the spine. The best way to take care of this is prevention, and that includes management of osteoporosis. And interestingly, management of osteoporosis not only prevents the cause of this, it prevents this from happening, but it also helps to aid the body in its recovery process after it happens. Sacral insufficiency is a type of fracture that happens in older women. You may have underlying osteoporosis in this as well, or a history of radiation to your pelvis, and it presents with sacral tenderness. X-ray may be fine, but again, like I mentioned before, this is the one where you have the bone scan, and it has that unique H-shaped uptake scan on it. Usually the pain resolves in 4 to 8 weeks. There's this last group. There's not much that is known about it or much recommendations that are given. It's just non-specific low back pain. It is very common. Thankfully, it is short-lived usually. It has a good prognosis, and the recommendation to us in general is to avoid aggressive interventions because usually it'll go away on its own. So in summary, these issues are the musculoskeletal issues are the most common causes of pain in older adults. The gold standard for determining the cause of musculoskeletal pain is a good history and a good physical exam. Sometimes we need to supplement that with labs and imaging. And back problems are the third most common reason for clinician visits by older patients. So it's important that we and y'all as the patient populace are well educated on these things. NSAIDs like ibuprofen and Aleve can be helpful in managing these things. However, they should be avoided in certain patients with high blood pressure, heart failure, chronic kidney disease. And again, like I said, imaging, usually the recommendation is to wait 6 weeks from the onset of back pain to obtain back imaging unless those red flags are present. Okay, that's the end of the first presentation.
All right, it's working just fine. All right, well, good afternoon, everybody. I'm Dr. Frazier. I am a first-year resident with UAMS Northwest. Again, I thank Dr. Wright for having me come here the past month and giving me the opportunity to meet with you all and to discuss your very many aspects of your lives and everything. You made us feel so welcome while we were here, and I'm just so absolutely grateful for the opportunity. Like Dr. Wright mentioned before, he grew up with my dad in Hope, Arkansas, and I just heard countless praises from my dad of how Dr. Wright treats his patients, and it's just an absolute honor to be working with him these past 4 weeks. And I look forward to coming back next year and doing some more work with everybody. So, without further ado, I'll just get started with this presentation. And some of the material in this presentation is going to be a little bit overlapped with what Dr. Kuhn has mentioned, because some of the conditions I'll be talking about, they're somewhat related to back pain, but there's just a little bit of overlap. And so if it seems redundant, it is, so just bear with me. And this is my first time giving a presentation as a physician, so if I seem nervous, I am. So, all right, so let's get started with how to approach hip pain. So there are multiple causes of hip pain. It is one of the most common causes of musculoskeletal pain that we see in the clinic. It's probably a little bit below back pain, but I'm not exactly sure. But anyway, some common causes of hip pain include traumatic fractures, like if you were in an accident, or if you fell over, or it could be secondary to osteoporosis that could lead up to a fracture. Osteoarthritis, bursitis, tendonitis, and lumbar spine disease. That's why I mentioned there's some overlap in this presentation, and of course some nerve dysfunction. Osteoarthritis is the most common cause. I do have another slide going over osteoarthritis. We'll get to that in a minute. Pain usually comes with walking, and usually relieved with sitting and lying down. When you come into the clinic, we will be assessing your history and doing a comprehensive physical exam. We'll be asking you how the pain is reproduced, whether you've tried different ways to manage the pain, whether you exercise regularly, and so on and so forth. During our physical exam, we will be assessing your gait. We will also be assessing your range of motion of the hip, so whether you can actually flex it, if you can extend it backwards, if you can move it outwards or inwards. And based on the limitations you have with your hip, we'll be able to determine have a better idea of what the cause would be. So if you are limping, the pain is pretty significant. If you have full range of motion, then it leads to something like a trochanteric bursitis, which I will get to later. If there is a short stride in your gait, like if you're just like dragging along while you're walking, then we're usually concerned that there is some somewhat significant cause causing your pain. If your range of, like I said, if the range of motion is normal, then not necessarily the hip is not the cause of the pain. It's just that it leads to something a lot less severe than what's going through our minds. So first off, osteoarthritis. You've all probably are familiar with arthritis and how it's presented and how it's caused. It's basically degeneration or wear and tear on the joint over time. It also leads to hypertrophy of the bone and the articular margins. On my next slide, I'll actually have an example of some X-rays of a patient that has arthritis in a hip, so you'll have a better idea of what it's supposed to look like. You have a limited range of motion with passive flexion or extension or abduction of the hip. The pain in your hip can also radiate towards your groin. So if you're coming in and telling us that you have pain in your groin area, as well as limited range of motion with the hip, then that gets us leads towards a diagnosis of arthritis. You would have morning stiffness lasting a little bit more than 30 minutes, and sometimes the pain is referred to your back or your knee. Some risk factors associated with arthritis: your increase of age, obesity, excessive joint loading, like if you are working at a job that requires manual labor, or if you like if you're a football player and you've had a prolonged history of overuse of the joint, trauma, and multiple types of deposition diseases, such as hemochromatosis, which is excessive deposition of iron within throughout the body, which accumulates in your joints, and something called alkaptonuria, which leads to this deposition of this black substance within your joint as well. And also, another risk factor with arthritis is developmental dysplasia of your hip. So if you were to look at an X-ray, I'll switch over in just a second, you would see narrowing of the joint space. You would see these bony spur-like lesions called osteophytes. And you also see scarring in the subchondral space, as well as some subchondral cysts. So if you're looking at the hip, this will also give you a better idea of the anatomy of the hip as well. Wish I had a pointer here that I would be able to actually point out some structures here. But let's see. If you're looking towards the right side of the X-ray, that's the pelvic girdle, and in between the side of the girdle is where the hip joint's supposed to be. There's a femoral head right there, and then towards the left, you see the head of the femur, which is the leg that connects your hip to your knee. That's the femoral, that's the top of the femur, and then you see the shaft of the femur going downwards. So anyway, on this right side, on this right X-ray, it's basically a very characteristic presentation of arthritis. You see the joint in between the bone and the joint space, space in between the pelvic girdle and the bump and the head of the femur is completely degenerated. Like there's nothing cushioning the bone. So that explains the limited range of motion and the pain and everything associated with it. And it's a little hard to tell because the vision is blurry, but you would also see these spur-like lesions that I mentioned before. Those are osteophytes. And it also leads to even more discomfort. This doesn't show and it's just, there's a whole lot of scarring and just wear and tear within the joint. So that's what you see. Yeah. All right. Now, this was already covered by Dr. Kuhn's presentation, but I'm just going to briefly revisit lumbar spine disease. As I mentioned before, sometimes when you have back pain, it is referred to your hip. One big example was lumbar spinal stenosis. It commonly causes thigh pain when you're standing and walking, and it's relieved when you're in a sitting position. Sometimes the pain can be felt on the side of the hip, and it also include the various neurological deficits that Dr. Kuhn had mentioned before, weakness and adduction of the hip. So when you're unable to lift your leg out this way as you normally would be able to, you wouldn't be able to extend the hip, and you would also have weakness in the greater toe. So that was just a brief revisit. Now, trochanteric bursitis. This is probably the most common thing we see in the clinic, aside from arthritis. It is a very common cause of lateral hip pain. It is basically localized, it presents with localized tenderness on the affected side of your hip. It's usually 1 to 1.5 inches below the superior portion of the trochanter, which is the, like if I go back to this slide, basically the end of the femur at the, see, again, I can't really point it out without a pointer. But basically, it's the end of the femoral bone. That's called the greater trochanter. Excuse me. So anyway, and it could also radiate down to the lateral side of the knee. You would usually have a normal range of motion, however, unlike with osteoarthritis, which is pretty limited. Some common causes of this are trauma, overuse, and weakness of the hip muscles. Basically, what the bursa is, it is a sac that sits in between your muscles and your bone, and sometimes if it is overused over time, it can get inflamed and it causes all this discomfort. You would have this pain when you're rolling over to your affected side. Say you're lying in bed and you wake up with this pain on your hip. It's usually because you've been sleeping on that side and it's causing an increased amount of discomfort. And also, you would also have it with prolonged periods of sitting. It could also be reproduced when you're resisting abduction of the hip. If you're like trying to resist moving your leg outward, then it could also be, you would also have it, and also from rising up from the chair. So again, that's another very common cause of what we're discussing here. Now, again, it's hard to point out the different types of nerves of the hip without me using something, but I'll try my best. Basically, another cause of hip pain is basically just dysfunction of a specific nerve. I'll be going over a specific nerve called the femoral nerve in just a minute, but I just wanted to point out a few of them. The femoral nerve basically extends down from the, it originates in the lumbar spine, and it comes down and forms this great nerve on the front of your leg. And also another big nerve that can be affected, and this was also touched upon by Dr. Kuhn earlier, is the sciatic nerve. It also originates in the lumbar spine as well as the sacral spine, and it comes along the back of your leg, and it basically innervates all the muscles and joints within the back of your leg. The femoral nerve innervates the front muscles of your leg. So anyway, and another thing I'll talk about later is something called the lateral cutaneous nerve of the thigh. It's also basically a branch of the femoral nerve group that I mentioned before, but it innervates the skin on the side of your thigh. It's not a motor nerve; it is a sensory nerve. So basically, if that nerve is affected, you would have reduced sensation on the lateral side of the thigh. Anyway, femoral nerve dysfunction and can produce pain in your thigh area, particularly in patients with diabetes or cancer. It produces focal tenderness of the hip flexor muscles. So that's basically your quadriceps muscles, and that also aids with flexion of the knee as well. Pain is in the anterior portion of the thigh with some altered sensation, and you'll also have a decreased quadriceps reflex. Those are your front leg, front leg muscles. I've already mentioned the lateral femoral cutaneous nerve, but I just wanted to bring up that the dysfunction of that nerve is very common in patients who have obesity, because when you have when you're obese, sometimes the nerve is compressed by the excessive amount of fat. So occasionally, you would have this occasional discomfort on the lateral side of your thigh. So one thing we encourage our patients is to take measures with weight loss. But usually this kind of sensory loss is self-limited. It usually lasts for 1 to 2 months. So it's not necessarily a serious condition, but it's just something that we like to address. Okay, so last few causes, and then I'll get right to treatment of the hip. The first one I have listed here is something called avascular necrosis. Now, if you're not familiar with this, it's basically when the blood flow to the bone is cut off and the cells in the bone basically die away. It's common in patients with sickle cell disease, and it's also common in patients who have a long-term use of corticosteroids, such as prednisone. It's also linked to peripheral arterial disease and metastatic bone disease, which can be spread from the breast, the prostate, the kidney, and the lung. And there's also something I wanted to mention called a psoas abscess. Now, what the psoas muscle is, it is a muscle that is in behind your abdominal cavity, and it is one of the main flexor muscles of your hip. And sometimes we've seen cases of an abscess developing in that area, and it can mimic a pain somewhat like appendicitis, but it can also lead to, it can also radiate pain towards the hip since it flexes the hip. So that's something that we have to consider when we talk about hip pain. And also, if you've had an inguinal or femoral hernia, it can also be a cause of hip pain. So those are just some few extra causes that I have listed here, and now we'll move on to my final thing, which is about treatment. First off, when we consider treatment for treatment for hip pain, we always start with conservative management. So that's like your basic pain relievers, like non-steroidals, such as Advil and Aleve, and Tylenol. Tylenol is something we usually have patients start out with. However, if you have a history of liver disease, then that can somewhat be contraindicated. So sometimes we suggest something like Advil along those lines. However, if you have a history of kidney disease, like Dr. Kuhn mentioned, non-steroidals can be contraindicated in those points. So at that point, we would recommend something like Tylenol or yeah. And also, if you have a history of bleeding disorders, like if you had a history of a GI bleed or if you have a blood clotting disorder, then we would generally not lean towards something like Advil. Also, corticosteroids can be injections, like steroid injections within the hip. Those can usually last you for about 3 months. And I also have listed here some non-pharmacological interventions, physical therapy, and exercise. We encourage regular exercise, at least 3 times a week, 30 minutes at a time. I would avoid high-intensity exercises such as excessive running and something that requires a lot of high contact. So I would lean towards something low intensity, like water aerobics, Tai Chi, moderate walking every day or every 3 days. And last resort, and this is mainly specific to osteoarthritis, but if conservative therapy fails, we usually can reach to a point where we have to consider total joint replacement. And weight loss is another thing we encourage. Weight loss decreases pressure of the affected hip, so if you're able to do so, then it could provide a lot of benefit over time. And also, if those don't work, you can also add some assistive devices like braces and to help improve your daily function. So anyway, that's all I have for you guys today. So we will move on to
questions and answers. I just want to mention, because I've become aware there may be quite a few people listening to this at home through the in-house TV. So if you have a question, if you're watching it on TV and have a question, the number to call is our on-call after-hours number that Dr. Frazier has, and that cell phone number is 479-200-9259. 200-9259. Well, I'm glad. I thought that great presentation. It's a good overview, and I like much of what you highlighted. I don't know how many people in here have had trochanteric bursitis, hip bursitis, but it is one of these things that can be such a source of pain in an ongoing way. You know, bursitis or tendonitis, the first treatment is if you can just baby it and not use that joint or the affected area, that's fine. But something like a bursitis, unless you're going to just sit, which we don't recommend either, you're going to do something every day that keeps it aggravated. I saw a woman once who came in with a history of 3 years of hip pain. She says, I know it's arthritis. I know you can't do anything about arthritis. That's why I hadn't said anything about it. But there's a big difference between hip pain and hip joint pain, osteoarthritis, which is true, can't be cured, and bursitis, which with an anti-inflammatory, and sometimes we put an injection in there, goes away overnight. But she'd suffered with it for 3 years. I felt terrible. Oh, and by the way, the location of pain, and I think Dr. Frazier said this, but hip pain, people automatically think hip. That's our hip, right? But when you see that up there, the ball and socket joint is like this. And so here's the leg, the femur, and the ball, part of the ball and socket joint. That's really deep to the groin. So people who have osteoarthritis of the hip, it's typically on weight bearing, and it's typically pain in the groin, not out here. So pain out here raises the possibility of especially bursitis, or even sciatica, but usually that's more in the back of the hip. So anyway, there are these patterns. Do you have questions for these guys? Don't go easy on them. Yes, sir.
You said that walkers and leaning over would help. Everybody tells me you shouldn't lean over like that.
I'm not sure I remember what you said.
Hello? Okay, excellent. So that was in regards to lumbar spinal stenosis. That is a position that can relieve the pain back there. Generally, though, if the preference is to have a good posture and walk upright. So that is our recommendation for everyone. However, what I was getting at, and maybe it didn't quite come through correctly, I'm sorry about that, but is that in lumbar spinal stenosis, these patients, they lean forward to get relief of hip pain, and sometimes that's the only position that they can find relief in. So our goal there is to kind of help them, live with.
When someone's saying that, that's kind of a clue. It may be spinal stenosis, but it's not part of the therapy. You wouldn't want to walk like that. But you make a good point. These roller walkers, which are so handy and useful, and at times just the best thing ever. But the big mistake I see is if you've got the handles too low, you're going to be pushing it like a lawnmower, and you may not have a back problem when you start off, but you'll have a back problem after a week or so. So you want to be sure it's adjusted right, where it's more, you want to walk upright with it. Good question. Yes.
Please correct me on this, but I think I heard one of you say normally you would delay imaging. And when you say imaging, I'm assuming you're saying x-rays or MRIs or things like that. 3 people, including myself, went recently to the Ozark Orthopedic Clinic, and the first thing they did to all 3 of us was x-ray.
So that's a really good question. So I would say, how long had your pain been going on when you presented to the orthopedic clinic? Only a few days. Okay. Well, maybe granted, I'm not a spinal or bone specialist. but the recommendations that we receive is unless it's one of those red flag symptoms that I mentioned, like concern for vertebral compression fracture, fever is concern for infection or history of cancer, those kinds of things, then our recommendation is to wait about 6 weeks before getting imaging, because the vast majority of back pain with conservative management like Tylenol or NSAIDs will go away on its own, and so that's the recommendation that we receive. Now, they're specialists and they know the minutia of things that we can't even imagine. So maybe they knew something or were worried about something that that we weren't.
Question? Yes, sir.
I assume osteoarthritis is in the back as well as the hip. It can't be cured, I understand, but is there anything that can be done to help prevent pain or stiffness?
So Dr. Frazier actually kind of mentioned a little bit of these in his hip talk, and I would bring them over to apply them to the spine as well. So having a healthy weight is very important. With every pound that you gain, you put an exponential extra amount of force on your bones, especially bones of the knee. And so having a healthy weight throughout life is very protective. Having healthy bones is protective, of course. But doing things that prevent trauma, like high impact sports, like Dr. Frazier mentioned, those are things that can later on in life increase your risk of osteoarthritis. Some people are just going to get it, but there are certain small things that we can do to try to prevent it down the road. But once you get it, it's not curative, and really the best things that we can do are just conservative management, Tylenol, NSAIDs, and those kinds of things.
No exercises.
So sometimes, I would imagine that physical therapy in some instances can be of benefit. I'm not familiar with any exercises specifically that would help with osteoarthritis of the spine, though. I'm sorry.
What about feet in relation to back pain or hip pain?
So are you referring to back pain that goes down to your feet, or?
Your feet in relation to people having back pain or
Just thinking of radiculopathy, I think.
Yeah. So there are certain conditions that I was mentioning before, and feel free to grab a handout to review some of those that are associated with radiculopathy, which is when you have potentially impingement of the nerve exiting the spine that can shoot down and cause pain in different parts of the body, definitely the foot. All the joints are connected, like the song, the hip bone's connected to the knee bone. That is very true, and sometimes problems with feet can, if you have painful feet, you may walk on them funny, which can cause hip or back pain. So these things, they all are connected, and without a good history and exam, it's hard. I wouldn't be able to answer specifically what's going on.
And just one more thing I wanted to mention. When we do a physical exam, whether you're coming in for hip pain or back pain, one thing that we do try to do is try to examine joints either above or below the affected area. Like, for example, if you're coming in for hip pain, we would also be doing an exam on your back and your knee. And likewise with the back, we would also inspect the hip. So there you go.
Yes. Brace yourself.
I have two questions, if I may. The first one is this, and that is that people are different in their response to pain. Some have a low threshold of pain. Some have a high threshold of pain. Wonder how you handle that in your medical practice, and I wonder if it's physiological or psychological.
Oh, that's a good question. Wow. Well, like you said, everybody's different. I think it's a little bit of both, honestly. Dr. Coon, you want to say something about that?
I think, definitely we see that there are real pathologic physical causes for pain, that many of which we discussed today that are common in the older population. But there are also other things that can present as pain. Depression can definitely present as pain. Also, chronic pain can lead to depression. So these things, psychologic, pathologic, physical causes, these things can be very strongly linked with pain. So it's really hard to elucidate the difference. But it's important that if someone is complaining of pain, that something's not right, whether it's a problem with mood, attitude, or there is an actual physiologic or pathologic problem. It's important that we figure out what is the problem and can meet that person, whatever their need is, and help them work through it. The other question is, different people have different tolerances of pain. That's definitely correct. In my experience, it seems that younger people, you see in the hospital people of different ages coming in with the same illness that can commonly present as pain. Different kind, maybe it's appendicitis, maybe it's pancreatitis. There are different things that can present with pain, and inevitably, what myself and several of my colleagues have observed, it seems like older patients will be much more comfortable with higher levels of pain than younger patients. So a patient coming in, a lady coming in her 25 or 20s, 30s with the same condition as someone who's in their 70s or 80s, a 70 or 80-year-old lady may be fine with some Tylenol, may not even need it, whereas the other lady may be asking for opiates around the clock. And that is definitely true. I don't really have a reason for that. It's just something that I've observed. But yeah, so the goal there is to definitely manage whatever pain the person is complaining of, but reasonably so.
Acupuncture.
I've heard, so I have not done much research into acupuncture. I've never been trained in acupuncture. I was not taught acupuncture in medical school. However, I have heard people getting benefit of acupuncture, but I'm sorry, I can't really elaborate on that.
I think there's no doubt that it helps in some people and for some things. There are quite a few conditions that those trained in acupuncture treat with acupuncture that there have been no studies that really support it, and yet there's still people who seem to benefit from it. So you bring up a really important area, Helen, about the whole interplay between the physical and the psychological. We're complex organisms, the human being, and the very aspects of this that you would find most interesting also happen to be things that increase with age. So even more likely in this room of us old guys, right? In this room, there are people who would, if they develop a chronic pain problem, unless they're doing all the right things to prevent it, depression's not going to be far behind. If you're depressed, physical symptoms may be a prominent part of the symptoms of the depression. Certainly fatigue always is, physical fatigue. So I think you make a really good point. I think it's powerfully interacting. I bet we all have some examples, and that's also why there's a big variation from person to person, and in everything, how we age, but also how we experience pain, anxiety. If we could all be blessed with one thing today and just be relieved of anxiety, or have an effective way individually to decrease anxiety or eliminate anxiety and stress. So eliminate stress from our life. Our physical experience would be altogether different too, because one thing's for sure, anxiety aggravates most symptoms. It really aggravates pain. There's no doubt about that. If you can really relax, you can take level 9 pain down to level 2. But that's easy to tell somebody else to relax. I can tell you that's about the easiest thing in the world and the hardest thing to do sometimes. But I think that's a powerful truth in medicine and just human aging, or just human beings. The interplay between the physical and the psychological. I'm glad you brought that up. These are inquiring minds. I know there are questions here.
What is your opinion about using opioids to alleviate pain?
Opioids work. They definitely work. However, they should not be used for managing chronic pain, except in one instance, and that's if a person is considering end-of-life care or is on hospice. Apart from that, that's a very general recommendation. There are specific instances where someone may need opiates. I know that there has been an opioid epidemic in the United States. There are a lot of patients, I suspect several of y'all may be those. My parents have been those as well, who have been prescribed opiates and have been on opiates for decades for chronic pain. And a lot of times the recommendation is definitely, if possible, to transition off of opiates onto something else. But if it's not possible, sometimes physicians will just continue to allow that patient to stay on that medication if they need to. But the recommendation for sure is opiates. They work, but only for acute pain unless someone is diagnosed with a terminal illness.
I would hate to practice without the benefit of that, because sometimes nothing short of that will work. But we've learned a lot in the last 10 years about how opioids can backfire. And the one big lesson, reminder, it's not that physicians didn't know this, shouldn't have known this, but there's none of us that's immune to being addicted. In fact, that's part of human nature and human physiology. And these things, especially, I know y'all know this, but oxycodone is extremely addictive. So it almost needs to be monitored by the week, if not the day, because once addicted, it can be a long way back, can be. So they're a blessing and a curse. We got to be wise about it. I see a question.
Okay, I'm not sure how to say this. I'm not having a very good week, so I'm saying what I think rather than what's appropriate. You've stressed keeping our weight down, staying fit, and I go to the mall and I'm horrified at the obese people in today's culture. And I hate to say it, but I go to doctors' offices and I see grossly obese nurses. I'm surrounded by people who are 3 times bigger than I am. And I'm thinking, why don't they know what they're telling their patients to do? What's wrong?
I hope you're not talking about myself. I know I have this large white coat. I chose its size intentionally. I think you bring a very good point. Physicians need to cure themselves, right? Cure thyself. So I agree with what you're saying. I think it is a very fair rebuke. The only thing that I would say to that is that there are a lot of other stressors that can be contributing to weight gain. And there are people that work in high stress occupations. Healthcare is one of those, especially during the COVID pandemic. That was a very stressful season for all of healthcare professionals, lawyers, bankers. Many people work in high stress positions where they unfortunately don't value those things like they should. And I think you bring a good point. I think it's a fair critique.
Well, I think it's a good point. But I think the combination of factors that lead to obesity are pretty complex in the individual. And it's easy for us to be judgmental. And of course, in some ways, the instruction is the same, but the person's ability to achieve it can vary terribly. It's one of those areas. I've seen people who so want to lose weight and who just can't, no matter what they do. And so it's an area where, yes, your point's well taken, but I think it calls for some grace, because the solution is easier for some people and a whole lot harder and impossible for other people. So I bet we could turn this talk into just that. I'm sorry. I would say it's one of the many products of a stressful society we live in, and that stress is easier to handle for some people than others. And and by the way, just in terms of what we're all concerned about, aging, if I were to write a recipe for successful aging, at the top would be find your stressless place. For many of you, it might be Butterfield Trail, but find a place where you can live with the least stress possible. I think you've heard me talk about activities. Successful aging is staying active. If you don't use it, you lose it, and that's really true. Well, there are activities that replete energy, like aerobics, and a whole lot of other things. Anything that makes you happy repletes energy. And then there are a whole lot of activities which deplete your energy. Those are the things you're doing because somebody else wants you to do them, not because you enjoy it, not because you get positive things out of it, but because you think you ought to. You better do it. And I invite all of us, whether it's our stress or anything else we're trying to address, is find the activities that really buoy you, and replete your energy. That was a well-placed yawn right there.
The weight, I give an example. My sister, she went through a really serious hospital program, worked hard, lost 100 pounds, but she has osteoarthritis. And the treatment for osteoarthritis causes her to gain weight. She had to decide that, yes, she didn't want that terrible pain. She did want relief from pain, and she had to put up with gaining some of those hard-earned pounds.
Any last question? Thank you so very much for your attention. Really appreciate it. Thank you, guys. Well done. Oh, next month, which I think it's going to be on the 14th, September 14th, 4 weeks from now, the topic is going to be peripheral neuropathy and other types of nerve pain. So I know that's something many of you know about, if not in yourself and friends, and we'll try to explain it. We'll study up between now and then. Thank you.